from generation to generation here in China. Older generations, they come from big families, and it was a really crucial thing in terms of their lives. But for younger people, it's not the same. They really don't want to have as many kids. It's not as important for them.
The one-child policy came into force in the early 80s to stop an already massive population exploding. Later, people in rural areas and those from ethnic minorities were allowed multiple kids. Yet, for the vast majority, over 3 decades, having more than one child meant being fined. China in 2021 is a completely different place. Young couples want different things.
When you look at birth rates throughout history, poverty tends to produce people. That's because every new human being is an extra pair of hands to go to work. Then along comes prosperity, and it's not as important to have kids for this reason.
Another factor is that this huge country has now produced generations of people simply accustomed to small family life. It might be hard to get them to change.
Stephen McDonnell reporting. And that's World Watch for today. I'm Sally Round. Kia koe, Max.
Kia ora, Sally, and that's Te Porongo o Te Paututanga for Wednesday, April the 7th. Just while we've got a few seconds left, a shout out to our awesome producing team today, Rachel Thomas, Patrick Hunn, and our awesome operator, Rachel Smith. We'll be back tomorrow with interviews and the latest news from Aotearoa and the world. But for now, from the Midday Report team, kia pai, tora.
RNZ News at 1. Good afternoon. I'm Marama Tipole. Growers and food processors are calling on the government to come up with a plan to let more Pacific workers into the country. At a media conference in Napier this morning, growers said it is the toughest season they've ever faced. A Hawke's Bay apple grower has had to let fields of apples rot because he hasn't had anyone to pick them. Bruce Mitchell of Chester Grove Apples told Midday Report this season has been...
Kia ora tātou katoa, tuatahi māku ka tīmata ake me ngā whakaaro nui ki tōku huamahi, ki te honore a Kiritapu Allen, ko reira tunu o ka whakaaro, me oku mihi katoa I tēnei wā ki runga iaia me tōna whānau. First of all, greetings everybody, and just as it was yesterday, our thoughts continue to remain with Minister Allen and her whānau during this time, and I wanted to express that up front. This morning, I was fortunate enough to receive the first dose of the vaccine with Ora Toa Health Clinic out at Takapu Wāhia, where they provided a fantastic service, Māori focused, and I enjoyed my time with them. We went through the process to receive the first shot. I can report that I am well, and I look forward to spreading the message around the vaccine and its efficacy and supporting it amongst our communities. Last week I started a roadshow around starting in Tāmaki Makaurau and into Te Tai Tokero, and for the remainder of this week I will be in the South Island promoting the vaccine amongst our communities, talking face to face in particular with Māori communities to make sure that we can spread the message and the information about the vaccine. So today I'm of course keen to update you all on the progress that we've made with respect to our Māori vaccination strategy and rollout. Equity and te tiriti o Waitangi are the overarching principles for our COVID-19 vaccine and immunisation program, and we've been developing and implementing specific responses, resources and activities to ensure that we achieve equity for our priority groups as described in the tiered system for the vaccine rollout. As you'll know, we've already announced our initial $39 million for Māori vaccine and immunisation package, and the Ministry of Health has been in talks with 62 Māori health providers about the $11 million fund, and I expect that money will be delivered to those providers within the fortnight. We also, as part of our commitment, are looking towards how we best roll out an engagement strategy to inform our people. We've used iwi leaders and iwi comms networks at this point in time, but with strong advice from our rangatahi Māori, we'll be looking to expand that across a number of social media platforms to ensure that we reach as many of our people as possible. Just finally, before I hand over to Dr. Bloomfield, we are also working with Maori health providers to grow the number of vaccinators. We have a significant challenge in bringing some of our whānau in to be able to be trained to be and able to administer the vaccine. We're working with Maori health providers first to identify who we can train and who are able and willing to do it, and then secondly making sure that the training is done with them in an efficient manner so that we can roll out and support more of the vaccine being delivered to our communities, in particular our Maori communities. Dr. Bloomfield.
Ngā mihi kia koe, minita. Kia ora koutou katoa. I would like to start today just with a quick overview of key aspects of our vaccine program. As you will know, New Zealand has 4 advance purchase arrangements with 4 different manufacturers, and we still have all 4 of those in place. We are currently rolling out a Pfizer-BioNTech vaccine-based program, and it's transpired that that vaccine is the one that has got one of the best profiles in terms of efficacy in clinical trials and safety, and as well as effectiveness actually in practice as it's rolled out in a number of countries. But our advance purchase agreements remain in place with the other manufacturers, in part to provide us with some risk assurance around potential disruptions for supply, which may come into place. We have not got any hint from our Pfizer deliveries to date that there's any problem with supply, but it behoves us to make sure we've got backups if needs be. But also we want to make sure that as the evidence around effectiveness and safety emerges, including in under 16s, that we have more than one option available. The vaccine that is next in line for going through our approval process is the Janssen vaccine, and the independent committee will be meeting on the 13th of April to assess that, and we're expecting to get a recommendation, and on the basis of that recommendation provide advice around a decision to use on the 15th of April, so that's next week. Of course, underpinning everything we're doing in our vaccination program is also us maintaining our elimination strategy, and in particular our very strong response at the border, which requires sustained and substantial focus and effort. For example, we manage about at least twice the rate per capita of returnees to New Zealand through managed isolation as Australia does. So this is a significant effort on behalf of not just the health sector but the wider government sector. All this is happening while we roll out the vaccine in a measured and safe way. We have started with those groups identified as being at high risk and where there is a strong payoff in terms of protecting New Zealand and New Zealanders. So those are the two key elements of our ongoing response. One strength to date has been the cross-government effort that has gone into the response. For example, personnel from the New Zealand Defence Force who have been a key part of our management of managed isolation. And this continues in the vaccination program. We have had NZDF logistics experts embedded in our vaccination program. We have had expertise from the private sector, and Fonterra has made logistics expertise available there. And there is considerable input from across government and indeed from across other agencies and organisations in New Zealand. In the context of quarantine-free travel between Australia and New Zealand that is now on the cards from the 19th of April, just a couple of comments about the responses in both countries, noting that we have the challenge of doing these 2 key things in both countries, keeping the virus out and vaccinating our populations. And you will see that the responses when there is a case in the community are very, very similar. I note also yesterday Australia was reporting a daily average of 9 Covid-19 cases detected at the border in the previous 7 days. Like New Zealand, Australia has been in the fortunate position of preparing for and rolling out a vaccination program whilst not having COVID-19 in our community and the obvious deaths and harm that has caused in many other countries. So the approval process we have taken the vaccines through has been our usual rigorous approval process, not an emergency use process. And whilst we have streamlined that process, it has been as rigorous as ever. And on our vaccine program, we have also been at pains to learn from other countries. We have talked directly with counterparts in Israel and in the United Kingdom about their experience there, what the challenges and issues have been, and indeed also the successful approaches they have employed. So all district health boards are now operating vaccination clinics, and so the number of people being vaccinated is expected to increase substantially over coming weeks. As we expected, the numbers did dip over the Easter period, and as both vaccinators and people in Group 2, the estimated 480,000 frontline workers and healthcare workers and people living in high-risk settings did take a break. We anticipate DHBs will be ramping up from this point to around 35,000 people being vaccinated a week. The total number of doses administered as of midnight last night was 90,286, and we're expected to hit the 100,000 doses administered milestone in the next couple of days. From today, our key vaccination statistics will be available on the Ministry of Health website in a quite comprehensive dashboard. It will be updated for the time being every week on Wednesday. It provides a snapshot of progress, including the number of people receiving their first vaccination. That in the current iteration is 71,013. The number of people who have received their second vaccination and are therefore fully vaccinated, which is now 19,273. There will be a graph indicating the number of vaccinations administered each week versus the forecast numbers, and for this week that is now 96%. The dashboard will also have information on vaccines administered on a given day, the number of first and second doses administered by individual district health board, and vaccinations delivered by ethnicity. We are also reporting on adverse reactions following immunisation, and this afternoon MedSafe, as you know, our medicines regulator, will be publishing its initial report on the safety monitoring of the rollout of the Pfizer-BioNTech vaccine to date. It will cover adverse events following immunisation, and that will also be updated weekly. The latest figures in that regard, up to the 6th of March, there have been 147 adverse reactions reported. I should say an adverse reaction is any reaction, whether it's mild or considered serious. Of those, there were 3 that were considered serious. Now, it's quite a low bar for serious. All these involved an allergic reaction of some kind, one of which was classified as an anaphylactic reaction to the vaccine in someone who had a history of allergies. All were managed appropriately on the spot. That's why we have nursing and medical oversight, and none of these people required hospitalisation or have any ongoing problems. There have been no new safety concerns with the vaccine identified here in New Zealand, and MedSafe's assessment is that the number and pattern of adverse events that are reported to date is very much in line with what they would expect and also what's been reported overseas. In terms of applications for early access to the vaccine for people travelling internationally, we've had 86 applications for travel reasons of national significance. All have been approved. There have been 41 applications by people seeking vaccination on compassionate grounds, and 23 of those have been approved to date. The online tool that allows people to find out when they can be vaccinated is proving popular, and so far the website has been visited over 270,000 times. And finally, just an update on the regular numbers. There are no new COVID-19 community cases to report today. There are 7 new cases to report in managed isolation since yesterday, and our 7-day rolling average of cases reported in managed isolation is 5. The total number of active cases is 81. And finally, I would like to say yesterday, the 6th of April, the Auckland February cluster was classified as being closed, as it was a period of 28 days since the last case in that cluster had been declared as recovered. And so the total cluster number was 15 community cases, and it's great to reach that milestone of having closed off that particular cluster. Thank you, Minister.
Thank you, Dr. Bloomfield. Questions?
Tako hia ngā Māori ko werohia ki te rongoa ārai mate.
Ko atu I te 8,000 tāngata I tēnei wātonu. Engari ka tahi anō kua whakatūngia etahi atu wāhi tukurongoa ki roto i ngā hāpuri Māori, no reira kāre kore, ki roto i ngā wiki e tūmai nei ko te hiahia kia kite atu i tērā whika e piki haere ana.
Any of those adverse reaction, if any of those people were Māori?
I don't have that information, and we can check and come back to you on that, and check and see if ethnicity is one of the descriptors in the report that MedSafe will be putting up. I would hope it would be.
Just on the 80. Kamutu, why should people trust you and what you say when you go to their marae?
Well, ko te mea nui ki roto i te ao Māori, ko te kanohi kitea, kia noho ākanohi nei ki te kōrero i ngā take, ka haere mai etahi rata, ki te whakautu i ngā pātai e hāngai puana ki ngā take hauora, hoi no tāku hei whakautu i ngā pātai e hāngai puana ki te ao tō rangapu. No reira, ki tāku e titiro nei ki roto i te wiki kua pahuri ake nei, i tutuki pai ai, ko te nuinga o ngā tāngata, e hari koana i tai mai au o tira mātou ki te tautoko i tēnei kaupapa.
Just on those 80, given the large number of vaccines which are in cold storage, why doesn't New Zealand ramp up its rollout now?
Well, as I said, we are actually ramping it up. From this coming week, we're expecting 35,000 doses a week to be being delivered, and it will continue to ramp up from there. I think it's important to point out that we've got a Pfizer-based program which provides some advantages. It's a highly effective and safe vaccine, but it is the trickiest one logistically and from a temperature storage, and also it requires pre-mixing in the vials. So we want to make sure that every single new venue that is brought on into the program, that is tested and that the procedures are all safe. So hence the choice of my words, measured and safe rollout and ramp up.
We've been, I guess, lagging behind a lot of other countries in terms of the rollout, though, in terms of per capita basis. Why is that?
Well, we're in a very different situation from most other countries, including those like Israel and the UK that I mentioned. The USA is another good example where they had major community outbreaks and transmission of COVID-19. So we've been in a very fortunate and hard-won position of being COVID-free, and we don't want to take our eye off the ball. So the vaccination program is rolling out in that context, and I think a good comparison is Australia, who is also rolling out at a similar, very similar rate, and we will be doing it in a fashion to make sure that it is safe. But you will see it ramping up. Yes.
It's been seriously criticised though in recent days for the slow pace of its rollout, and we're far behind them.
Well, we're not far behind them. We're actually about the same, very similar proportion of the population vaccinated to date. But just to reiterate, we were in a position where we could take a measured and steady approach to rollout. Australia and New Zealand were the first two countries to approve the Pfizer vaccine under a proper approval process, not under as an emergency use measure. And of course, we wanted to do that. And now, as we roll out the vaccine, we want to make sure that every site we are rolling it out on, it is being done safely, and that we are adding value to our already good elimination approach.
The Australian comparison, Scott Morrison just hours ago saying that the issue with their rollout was the lack of supply and the fact that they can't get AstraZeneca into the country. You're saying that the issue in New Zealand is not supply, but the literal mechanics of the rollout, correct?
Well, it's standing up the vaccination program on top of continuing, as Australia is, to run our healthcare system and deliver healthcare to all New Zealanders, and a significant effort that our country is putting into, as is Australia, to managing our border. That is a significant deployment of our workforce, health, NZDF and other government workforces, as well as the private sector. And that's been the mainstay of our success to date, and we don't want to take our eye off that ball. So we are rolling out the vaccine in that context. And I think, we have made a very good start to this program. We are delivering a safe program for New Zealanders. We want to build trust and confidence in it, and now it is starting to scale up.
Do you have targets for where you want to be as of today, and where are you compared to that target?
So you will see in the data that are on the website that there will be an expected amount that will be delivered every week, and we will be reporting the actual versus expected. To date, we're 96% of expected, And each district health board has got an indication of the amount of vaccine over coming months that it will be expected to deliver for its population, so that we can that it can plan, or that each DHB can plan to deliver for the whole population, and including reaching those groups who need additional effort to be able to access the vaccine, so that we are meeting those plans.
You said that there was 86 so far.
The people of Whanganui, West Coast, no one's been vaccinated in those DHBs. Mid-Central and Hutt Valley have had no one fully vaccinated for second dose. Should people in those DHBs be concerned that they're not seeing the vaccine yet?
I think if you look at the data that will be on the website today, is that what you're looking at? Yeah. That may be up to a couple of days ago. There is vaccination happening underway in each of our DHBs, and so no, I don't think people should be concerned. They should be confident that the plans are being put in place in every DHB to roll out to ensure that all eligible New Zealanders can be vaccinated.
There were 86 special exemption vaccinations requests, or were they requested or provided thus far?
So those were the national interest ones. There have been 86 applications. All have been approved. The vast majority related to Olympian athletes, and there were a couple related to diplomats travelling overseas.
You mentioned, I think there's about upward of 8,000 Maori who've been vaccinated so far. That doesn't seem to line up with the proportion of the general population, let alone the proportion of border staff. So is there a problem with Maori wanting to get vaccinated?
No, I don't believe there is, as I've worked with Maori health providers to build their capacity and confidence to be able to deliver the vaccine. I know that in the coming weeks, quite a large number will be of vaccine centres and providers will be opening up, in particular in Tāmaki Makaurau, in line with what we announced approximately 8 weeks ago around the tiered approach to the delivery of the vaccine. So we'll start seeing those popping up more in Tāmaki Makaurau. That'll reach our people, and I expect, as I said in Māori, for those numbers to be rising significantly over the coming weeks.
Why aren't there more Māori getting vaccinated then?
Well, look, first and foremost, we've got to have the ability to be able to vaccinate them. And for example, I was in Kaikohe last week talking with the local Māori health provider there, who, whilst establishing their vaccination centre and facility, they've identified some of the challenges they have with regard to infrastructure to be able to deliver it on a bigger scale as we look towards the second half of the year. So our job right now is to make sure we give them the capacity and the support to ramp that up with an eye to the second half of the year. And I'm going to say we're on target as far as I'm concerned as we laid out the vaccination rollout plan for Māori.
What are those capacity constraints that Māori health providers have spoken to?
I've already mentioned one of them. Those are vaccinators, those to actually deliver the vaccine. Some of the other ones, for example, are how do you get remote populations to their particular centre, and also just broader workforce challenges. We know that the health workforce, broadly speaking, has been under the pump over the past year and even before then. So a lot of them are already saying that they've got nursing difficulties, they've got capacity difficulties with staff to be able to administer the vaccine safely. So they're quite respectful that they're quite pleased with how they're being able to take the time to get this done and get it done right.
To address those workforce capacity constraints, then will you be training, or will providers be able to train community health workers, which make up the bulk of their workforce?
Correct. So we're working with Māori health providers right now to identify those. Even some of those who have gone on to retire have been putting their hands up in Māori communities. And we'll be looking to supporting those Māori health providers, identify them in the first instance, and then train them to get them prepared, in particular with an eye to the second half of the year where we look to roll out en masse.
There's an exception there then, because at the moment it's nurses and a few others that can administer the vaccine, so there'll be an exception there for Māori health workers to administer the vaccine?
Well, like I said, we've got to identify those people with those Māori health providers. We're going to do our best to raise those numbers. Whether or not there's an exception, I won't comment on that.
I could comment, Minister. Yes, we've looked at this in the vaccine program and have approved an exemption to be able to train our current non-regulated workforces, including kaimahu, who might be working for Māori health providers and other providers, to receive training to be able to vaccinate as well, which I think is a great initiative. It will obviously add to the skill set for those for that workforce, and also, of course, increase the workforce available, particularly for Māori and Pacific providers. I don't have a sense yet of the number of people, but it's a pretty sizable workforce.
Bloomfield, you can report daily on the COVID numbers. Why can't you report daily on the vaccinations, or are your IT systems not up to scratch yet?
Our IT systems are very much up to scratch. We're just, at the moment, while we're still relatively low numbers, are going to report weekly, but I'm sure that will change to daily as the numbers start to scale up.
Minister, you received your vaccine today, but when will the members of the Defence Force serving overseas get theirs?
Oh, look, my understanding is that we've been in contact with our service people overseas, as well as the countries they serve in, to look how we might support, in the first instance, those countries supporting our defence personnel to get vaccinated. And if that can't happen, then of course we'll look towards how we'll do that for ourselves, for our own people.
Do you have a time frame of when you can guarantee they'll be vaccinated by?
I can't give you a time frame right now. I can say, however, that the vast bulk of our uniformed service people have already been vaccinated. In fact, many are going back now for their second dose of the Pfizer vaccine.
Dr. Bloomfield, just back on the. Oh, thanks, Ben. Just back on the 86 with the black caps. You said that the Olympians were in there, a couple of diplomats. Were the black caps in that rollout?
Not from my recollection. I don't take any detailed interest in exactly who is there, but the majority of them were Olympians. And in fact, some of those Olympians are due to depart fairly soon.
Bloomfield, last July you signed off on a mental health report from the Office of the Director of Mental Health Services. It was being delayed another 8 months on the direction of Robin Shearer, who was worried about the amount of statistics in the report. Eventually a lot were edited out. Are you totally comfortable with the way that whole process went, given you had actually already given it the green light to be published?
Yes, I am comfortable with the process, and what I can say is that all the data in the previous reports and that has been reported since, I think, 2010 is still widely available, and we've actually clarified that with Sean Robinson from the Mental Health Foundation. So the input that Robin Shearer, who was the Deputy Director General of Mental Health and Addiction, was providing was to try and ensure that the data being presented in that report were, I guess, not just repeating data that were already available in another way, but we're able to add value to that. And I think if you look at the report that's just come out with the latest data, it is still very comprehensive. There is a lot of data in there. There was a question.
Dr. Blicker, on the bubble, the COVID-19 minister said you considered Australia to be a low-risk country for some time. The systems were in place to give the tick for the bubble. So can I ask, what were the last things to come online? What were you waiting for? What was the last piece of the puzzle to tick it off?
The key issue was getting agreement around the process for sharing information and the protocols for responding in each country if there was a case on either side of the Tasman. And once we had that agreed and in place, and we have had a chance over the last month or two with the cases we had here in Auckland, and also the various cases they've had in Australia, to get those systems and test them and get them in place, and we now both feel comfortable that that system is in place and will work well.
Just to follow up on that, the Prime Minister has also said you'll be the one to decide whether pre-departure testing is necessary, so here to travel there or over there to come here. Can you explain how that might work? Because at the moment it's not required, but you might change your decision at any time, right, and then people will need to get tests. How will that work? What are you feeling about that?
It would be context specific, and it would be as part of a series of responses to cases on either side of the Tasman, although...
So there's no widespread need for pre-departure testing?
That's not the intention at the moment, no. As part of quarantine-free travel, we feel confident that pre-departure testing is not needed routinely, but if there were cases in a particular state or in a community and there were flights coming from there, that may be one of the things that will be required of people.
Has the decision been made yet on updating the list? Has a decision been made on updating the list of designations that have been deemed to be higher risk, the air routes?
Sorry, the designations?
Designations of higher risk air routes.
There is no change to that proposed as yet, and we are still working with the same series of definitions, and those are updated regularly depending on what is happening in different countries. For example, we've seen over the last few weeks quite a big increase in infection rates in India, but a decline in infection rates in the UK and the USA, so we're watching that on a regular basis.
The only routes that are higher risk right now are Los Angeles and San Francisco. Does that reflect the country's risk profile? Is that really where the risk is coming from?
It is at the moment for direct flights, and this relates to flights that are this relates specifically to New Zealand-based aircrew and what is required of them when they return to New Zealand.
Dr. Bloomfield, are you absolutely satisfied we have the resources to contact trace additional people in what could be a more complex scenario with more Australians being here in a fortnight?
Yes, I am satisfied, and that was part of the advice I provided to Cabinet.
Official information shows that during the February outbreak, no one from the National Investigation and Contact Tracing Centre called Case L, and no one visited the home of any in the family. Do you have the resources to door knock people of interest?
Yes, we do have the resources, and that's done by and through arrangement with the local public health unit, and usually they use local Maori and or Pacific or other providers to support that, and so there's a well defined system now for doing that. In fact, that was in place.
If you have the resources, why did you not do that?
Well, I think we've traversed that actually back in February as to what happened at the time, but what I can say is that there are clearly protocols and resources in place, if required, to door knock for people who we need to follow up with face to face.
Yesterday was the official end of the Valentine's Day cluster, as it were. Have you come any close, or your officials become any closer to figuring out how the virus was allowed into the community?
No, we haven't, and that still is something we haven't been able to solve, similar to the August outbreak last year in Auckland. My sense is it most likely relates to an incursion somewhere in the Auckland airport precinct where, if you recall, case B, it was one of our original two cases worked. However, we haven't been able to identify exactly the way that person was infected.
Is it that we'll just never know?
It's very likely we will never know.
There's a bit of a debate going on in Parliament at the moment about being able to buy and consume alcohol on your Easter Sundays, Anzac Days, Christmas Days. Do you see it, I guess, as a bit of a backward step in terms of health if we're to make alcohol freely available like that 365 days a year? Or would you like to see sort of an overhaul, I guess, in looking at alcohol as more of a health-based issue and not subjecting it to certain days, but actually looking more at sort of how you purchase alcohol, how much you purchase alcohol, where, etc.?
Well, I think, as you pointed out, there's a debate in Parliament about that. We haven't been asked to provide advice at this point on that debate. I do think the issue of availability is, of course, one of the considerations around preventing harmful use of alcohol and the harm that can result from alcohol use, but we haven't been asked to provide specific advice around availability on certain days.
I mean, abortion obviously got taken out of the Crimes Act and is now treated as health policy. Do you see alcohol and I guess the abuse of alcohol, and you know, it's well documented that there's significant effects from that. Do you see it being better treated, and perhaps Minister, you could comment on this as well, being better treated as more of a health issue?
Well, my view would be, and again, I haven't been asked for advice on this, and obviously our job would be to provide public health advice to input to broader government policy on the issue. I think there is already a strong health dimension to the sale of liquor and the sale and supply of liquor, and also the health sector response and ability to provide, for example, addiction services to support people who may have alcohol addiction.
So do you have any comment on that, and do you support your colleague Karen McAnulty's bill?
Look, I haven't seen the bill, and I know Mr McAnulty has discussed it with a number of our caucus. I, like a lot of my colleagues, have said that we'll wait for the select committee to do the work that they need to do to see exactly what the thoughts of the community are on this. As the Associate Health Minister, of course, we see the impacts of alcohol on our communities. I'm responsible for diabetes amongst other things, and I know that if we don't treat this as a health issue, then those other matters like diabetes won't be helped.
As a Māori health minister though, does it sit comfortably with you moving towards making alcohol more freely available on all 365 days?
No, it doesn't.
Maharaharatanga kua whakaputa I te iwi o haerenga, ngā maharaharatanga mō te rongo arai mate. Ka piti he hātau ki te whakatau I te Maori o te iwi?
Ko ngā pātai nui ka puta mai, tuatahi, ka pēhea au te toro atu ki tēnei rongoa, ko te pātai tuarua, ka rangona, mehe mea he mea kua tika te mahi rangahau e pāna ki te rongoa nei, koina te take ka haere ngātahi mai ngā rata ki te whakautu I aua momo pātai. Engari ko te nuinga ko atu I te iwa te kaupai heneti e tino aro mai ana ki wā tātou haerenga me ngā kōrero kei roto I te hui. Engari hei te otinga ake, kei ā rātou tonu te tikanga, hoi no tāku hei whakautu pātai, hei tuku kōrero.
Te tōreo, kua whakamahia koe te reo Māori roto I rāhui, hei kawe aki ngā kōrero. What difference does te reo Māori make when explaining something like vaccination to Māori communities, and how significant is that for being Māori?
In particular for our kaumātua kuia and our rangatahi Māori, who prefer to articulate themselves in te reo Māori, having the ability to be able to respond to their questions in te reo Māori gives them a level of reassurance that at least their voices are being heard in places like here and at the decision-making table with respect to Covid-19. Nō reira, ko te hua nui ka puta mai, e hoa ko te reo Māori kei runga, koina te huarahi ki te ngākau.
Cases that we're catching at the border and passengers coming out of India, why do you think that is? And is there any suggestion that the pre-departure testing taking place in India is not up to scratch, given the numbers that we're getting here that are positive on that day zero testing?
We've had a specific look at this because that was one of the concerns raised. Our conclusion, if we look at the nature of those cases, in particular the cycle threshold, the CT value of the tests, our conclusion is that the majority of those are people who may be returning a negative pre-departure test, and there's nothing to suggest there's any problem with the pre-departure testing or the documentation of that. But their CT value suggests they are being infected post-test and before and during their travel to New Zealand, in particular as they transit and travel through India on their way to either Mumbai or Delhi, which for some can be a lengthy trip. And that so it's more a reflection of the high rates of infection in India at the moment, rather than a problem with the pre-departure testing, and we have looked at that specifically.
Bloomfield, on a different subject, what benefit would it be to the country to see a nationwide rollout of self-test cervical screening?
So on cervical screening, we currently have a smear-based program, and that's served New Zealand very well. One of the things we do know is that there have been for many years lower rates of cervical screening amongst Māori and Pacific women, and there are a number of initiatives in place to try and improve that. The key decision and the key next step is to move that program from being a pap smear-based program, a cytology-based program, to an HPV testing-based program. Within that, and the government is actively considering the funding for that program, within that there is the opportunity for self-sampling, and we know from a couple of studies that have been undertaken already in New Zealand that that has a high degree of acceptability, particularly for Māori women. So that does open up the opportunity for women who may be put off by the current approach to screening, cervical screening, to participate in an HPV-based program. But just to reiterate, that's something that's under active consideration, so I can't comment further on that.
As Associate Minister of Health Māori, will you be pushing this take to get self-testing for the HPV virus up and running?
We've been talking with Dr. Bloomfield and the Ministry of Health for some time now about this particular matter, as well as some of the medical experts with respect to this, and it is, as Dr. Bloomfield has already mentioned, currently under consideration by this government, and it's certainly something that I'll be vouching for.
Will that funding be budget 2021?
It's currently under consideration, and I don't want to get ahead of the budget process.
Just on COVID, I just want to ask, you mentioned the 11 million for the Māori health providers. There was also 24.5 million for community-based vaccine support services to help Māori health providers. What are those support services that are being funded there?
Oh, well, those are the things that we're exploring with the Māori health providers. The ones in Tāmaki Makaurau, for example, have different needs to those who I visited in Kaitaia and Kaikohe recently. So we work with them. They, as part of the process with respect to the funding, they've got to provide a pretty clear plan, and each one of them, that I've seen at least, are quite different in nature. And we'd be more than happy to explore many of the ways that make this vaccine accessible to our people, which is probably the primary question I get as I've been around the country, is about the where and when can they receive it.
Essentially funding Wānanga with that money.
Possibly. I mean, those are, we're not taking options off the table. If anything, we're wanting our Māori health providers to lead by bringing options to allow us to consider so that we can deliver the vaccine to our whānau efficiently and in a Māori way.
Would you have over who vaccinates them, either Māori or non-Māori? Will people be able to say, look, I'll go to a vaccination centre, or actually I'd like to have it done by my local GP or nurse at my family clinic?
Yeah, look, we're encouraging our Māori communities to go to the place where they feel safest and where they have that relationship. For many, it's with their local GP or through another clinic, but we know that Māori health providers, in particular those densely populated Māori communities and those hard-to-reach Māori communities, play an active role and a key role in making sure that they can access it. So all of those options are available. I think in the first instance, we're just sharing the information about the vaccine so people can make an informed decision.
If you use a local GP?
Pardon, sorry?
Will it cost anything if you choose a GP over it?
Oh, we've made it clear that this vaccine will be free.
No matter who puts in for you and for the general population too, for non-Māori, it's also, you can get it, you will eventually be able to get vaccinated from whomever you're able to procure a vaccine from.
Yes, there'll be a range of options available, and that the number of the number of types of vaccination centre will increase as we roll out into bigger groups. So at the moment there are some GP hubs are being used. The role of GPs will increase as we get further through the program. Pharmacy will also be another venue, but wherever people go to be vaccinated, it will be free. Mark?
On the Johnson & Johnson vaccine, without presuming the determination that will be made next week, if it is approved, do you have an expectation that some supplies of the vaccine might begin to arrive, and when that might occur?
At this point, we're confident of delivery in Q4 this year, but are in discussion with the manufacturer about delivery in Q3, and it will be we will be more confident about those discussions and the outcomes of them once we've obviously once the approval is there, pending the decision of that advisory committee.
Why is it a delivery in Q4 or Q3 when other countries have managed to get some of this particular vaccine, already?
That was what was originally negotiated in the advance purchase agreement nearly last year. Remembering that when these agreements were negotiated, of course, none of these vaccines had clinical trial data, and none of them had been through an approval, even an emergency approval process anywhere. So that was what was negotiated then, and obviously once we if the approval is achieved here, then we can go back and further the discussions around earlier delivery. And in fact, we saw that with Pfizer. In fact, Pfizer brought forward its first deliveries into February, and we fully expect we'll be able to have good discussions with Janssen around that too.
Last couple of questions, thanks.
You obviously didn't know in November that the vaccines would be sort of available quite so quickly, but other countries have managed to get those quicker. Is there something that is in our contract that isn't in theirs, restricting the timeline for that delivery?
Well, different countries and jurisdictions did negotiate different terms with the vaccine companies. If you also think about our deliveries in terms of our planning and standing up the program while maintaining our elimination approach, and also, again, being confident about putting them through a proper approval process before their decision to use and then rolling them out, I think our timing has worked out well, and as I say, very similar to a country like Australia, which is also taking a similar elimination type approach.
But can you give us an update on the Ministry of Health's research around long COVID? Is there any support for sufferers of this now?
So two separate things there. I'll have to come back to you on where we're at with the, we were doing an expression of interest process around research around long COVID, and I'll have to also come back with you about support for people who are experiencing longer term symptoms from COVID-19, but we'll come back to you on that.
Was cost ever part of the conversation? Because we know from reporting overseas that when it comes to the Pfizer vaccine, who got it first wasn't who needed it most, it's who was willing to pay most. So the Israelis were paid, the Prime Minister there admitted $30 a dose. The Europeans were only willing to pay $15. Is that part of the reason that we're down the queue?
So I just want to come back. I don't think we're down the queue, remembering that we have negotiated and have guaranteed delivery over the coming 6 months of enough Pfizer-BioNTech vaccine to vaccinate our entire population, and also to support vaccination in the Pacific Islands that we're taking an interest in and supporting. Furthermore, we have 3 other vaccines that in our portfolio as well. Price was obviously part of the negotiation, but it wasn't a deciding factor in sealing the deal with any of our manufacturers.
So do you see a time when someone who can prove they've had a vaccination in another country won't have to go into MIQ in New Zealand, apart from Australia?
Yeah, this is an active discussion, and it won't be. It's a discussion and consideration not just for New Zealand but for other countries. And I've just been in a conversation with people about this. Proof of vaccination by an individual will be one consideration, but possibly more important will be what is the overall vaccination in a country where someone is travelling from, and what is the rate of infection in that country? Because first of all, we know vaccination is, even with these highly effective vaccines, doesn't confer immunity on everybody. So what we're most interested in, of course, is what's the likelihood that person travelling to New Zealand is infected with COVID-19. Their individual vaccination status will be important, but so will be the nature of the infection in the country they're in and the level of overall vaccination in that country. These are all matters that need to be considered, and obviously we'll be looking to see what other countries are doing as well in that regard.
Thank you very much.